Buon pomeriggio a tutti, io sono Alessandro Barbera della Stampa.
Good afternoon, I'm Alessandro Barbera from La Stampa, the Daily. We are here today with Michael KREMER. And together we will be discussing one of the most relevant topics of the current Trento Festival edition. For years we have discussed in Italy about providing vaccines to our children. After decades, we are now discussing whether vaccines are harmful or not. And for some of us, this has become almost a fight. We heard recently about the death threat to Mr. Brioni, a doctor at the San Raffaele Hospital in Milan, who has been fighting to have vaccines being administered to all children. So while we are discussing in Italy about one of the major advances of the 1900s, in other countries vaccines are still far to come. According to UNICEF data, out of the 7.6 million infant deaths, that means infants below 5 years of age, that occur every year in the world, so most of these are due to acute respiratory diseases, measles, and today Mr. KREMER is going to talk about worms. So it is one of the most relevant diseases in the African countries. So all such diseases can be easily fought against with nets, with vaccines, with simple prophylaxis, most of which are unknown to people living in low-income countries. But the same applies to drugs, drugs that can be used to treat these diseases that are really accessible to citizens around the world, with the only exception of, again, low-income countries. Mr. KREMER is definitely the right person to talk about this topic. Mr. KREMER is a Gates Professor of Developing Society at the Economics Department of Harvard, is a member of a number of associations, and Mr. KREMER has been focusing his research on health, education, water in poor countries and Latin American countries. He was awarded several prizes, and one of the core points of his research study is the use of incentives to lead people in the low-income countries accept to be vaccinated. Mr. KREMER contributed to the Advanced Market Committee to foster private investment across the world on research on vaccines and their distribution in the poorest countries. At the end of 2010, he was appointed director of the most important U.S. agency to support poor countries. He works with numerous organizations devoted to poverty. He's one of the founders of World Tech, an organization that enrolls young students and researchers who are willing to teach for a certain period of time in the poorest countries around the world. Today, Mr. KREMER will try to give an answer to the following question. Is it right to have poor countries pay for health? What is normal for us? What is almost a duty for us? That is to say, contribute to the national health system to pay for everybody's health and allow everyone to be treated. In other countries, in the poorest country in particular, this is a real issue, because the question is whether it is useful to pay for health care. There are numerous studies showing that in a number of cases, paying even a small fee discourages prevention in poor countries. So the question that Mr. KREMER will try and give an answer to is whether, well, first of all, how prevention should be carried out in poor countries, how health policies have to be approached, especially in African countries, and whether it would be possible to introduce incentives, if there are incentives that really work, to, again, attract people and lead them to accept preventive treatment to save millions of lives in these countries. Professor KREMER will deliver a speech that will last roughly 40-45 minutes. At the end, the Q&A session will follow. You will have the opportunity to ask questions, so please write them down now. Thank you very much.
Professor KREMER, and it's your time.
Right. Grazie. So some of the deepest health inequalities are inequalities between countries. So whereas in rich countries, people can expect to live to their 70s or 80s in some cases, in poor countries, some poor countries, it's even in the 40s. There are cases where out of every 1,000 children who are born, more than 100, and before, until recently, many more than that, would die before they became age 5. There are many people dying of preventable diseases for which vaccines exist. There are people dying because they don't have safe water. And but what I'd like to talk about today is not focus only on the deep inequalities that exist, but also on what practical steps can be done to address them. And in fact, there's a huge amount that can be done to address them. So let me just illustrate that principle by showing you the case of incomes and life expectancy in the United States in 1900 and in Vietnam in 2009. So you can see the U.S. in 1900 is much, much richer than Vietnam was 2009. That would still be the case now. But if you look at life expectancy in Vietnam is actually quite good. Much, much better than it was in the U.S. in 1900. So how is Vietnam able to achieve this remarkable health performance at very low income levels? Well, there's been a fundamental shift in the possibilities to generate health since 1900. There are many historically, the big killers were infectious diseases. And still, in poor countries, infectious diseases are a major source of death. But we have many very cheap, very effective technologies that can solve these problems, or at least greatly improve them. Things like vaccines, like antibiotics, like water treatment programs, like for malaria, insecticide-treated nets. And it's those sorts of things that create at least the possibility to substantially reduce the inequalities across countries in health. But, as I just said, many people in low-income countries don't benefit from these technologies. Children who should get vaccines are not all getting them. Some countries have very high immunization rates, but others, like India or Nigeria, have much lower immunization rates. I'll talk some about the case of water today. But what I'd like to do is to start out with the standard economic model of this. And the standard economic model, one standard economic model at least, sees investment in health as a form of investment. That's the human capital model of health. So in that model, people will invest on their own as long as the benefits exceed the costs. Now, there might be a case, if you stuck to that standard economic model, there might be a case for the government to subsidize health, because if I get a vaccine, not only do I protect myself, but I also I don't infect others. And that creates a very standard economic logic for subsidizing prevention of communicable disease. But it would also depend on will people's behavior be affected by the subsidy? If people's behavior won't be affected by the subsidy, then maybe a subsidy isn't so warranted. It also depends. You have to finance that subsidy from somewhere. If raising the taxes causes big distortions in the economy, then that would also suggest maybe the subsidy should be smaller. If it doesn't cause big distortions, maybe it could be larger. So let me illustrate some of these points by looking at the case of worms that affect humans. So about 1.5 billion people around the world have, in low-income countries, are affected by one of two broad categories of worms. Soil-transmitted helminths, that's hookworm, whipworm, a roundworm, and schistosomiasis, also called bilharzia. School-aged children are particularly susceptible, in part because sometimes these worms enter through the feet, and children are less likely to be wearing shoes. They also are very important in transmission because adults are more likely to defecate in the latrine, but children may defecate outside. This is some pictures of some soil-transmitted helminths. And then bilharzia is different. It has part of its life cycle in snails, so it's particularly prevalent near freshwater sources. This is a picture of snails near Lake Victoria out in Kenya. Okay. So the worms can affect nutrition because they absorb some of the food that the human eats. They can cause anemia. That, in turn, has been shown to have cognitive effects. The effects depend on the intensity of infection. If you just have one worm, that's probably not going to cause noticeable symptoms. But if you have a lot of worms in your body, then you'll have bigger effects. And the distribution is very skewed. A lot of people have just a few worms. Some people have very heavy loads. And it depends also on the prevalence in the society. So there's unanimity in the medical profession that if somebody's infected, it's the standard of care to treat them. The medicine's known to be efficacious, it's safe, it's also very inexpensive. So these medication is routinely given in very large quantities to farm animals to help them gain weight. That's standard. It's very, very heavily used. But while farm animals are getting them, many people are not. And one of the reasons for that is that whilst the medicine is very cheap, like 2 cents per dose, in fact, although many of the companies are now giving it away for free, the diagnosis is expensive. You have to test a stool sample. That's expensive. It's imprecise. And it's logistically very difficult because you have to get the stool sample, test it in the lab, find the same person again, and get them the treatment. So the World Health Organization has long recommended that in places where there's high prevalence of the disease, more than 20% or more than, there be treatment once every year, and where it's more than 50%, multiple treatments per year, usually 2. And that's been considered to be highly cost-effective by a number of organizations. Okay. I wanted to talk about some research that I was involved in this. I'm going to give 3 examples. The first one is worms, then I'll talk about a water example, and then I'll talk about a vaccine example. So on the worms example, I was involved in an evaluation in Kenya. There were 75 schools. There's high prevalence in this area, so we found big effects, but they might be smaller in other settings. The program, 25 schools, there was a small NGO doing this work. They began the treating the children for worm in 25 schools, then they went on to another 25 schools, and then on to another 25 schools. And the order in which they did this, they basically put them in, made a list of the schools, and then counted off 1, 2, 3, 1, 2, 3, 1, 2, 3, to find out which group, who would be treated when. So here's a picture of the deworming day at the school. The teachers administer the drugs. These are very simple and safe drugs. So the World Health Organization says teachers can recommend them, can provide them as long as they're trained by health personnel. So we first analyzed the short-run effect of this, and we saw the worm infections went down. But then, much to our surprise, I don't say much to our surprise, but we weren't necessarily expecting this at the beginning, but we found reduced infection among untreated children in treatment schools. So not all the children got treated, but even the ones who didn't get treated seemed to have lower prevalence. And also, people attending other schools within 3 kilometers. We initially thought it went out to 6 kilometers, but we had a programming mistake. So it only goes out 3 or maybe 4 or 5 kilometers, but not 6. We also saw an increase in school participation when the children were treated. So they were, for every child treated, you got 8.5 percentage points higher enrollment, or higher school participation, a combination of higher enrollment, less dropout, and greater attendance among those still there. So this has been, you can compare this to other programs designed to increase school participation, and it looks very cost effective. So this is a chart from JPAL where they looked at various approaches for increasing school attendance, and you can see that, I can't read the numbers from here, but I believe that's 12.5. For every $100 that's spent on deworming, there are 12.5 additional child years of school. So it's very, very cheap to get an additional year of school through this. Now, some of these other programs, I should be clear, I actually think the other programs that look smaller are also very good programs. So I don't think you should only try to keep children in school when you can do it this cheaply. These are all cases in Africa. Here's something in South Asia. Again, the tallest bar there is a combination of, this time a combination of deworming and iron provision. Okay. So I should say that in our initial study, we saw that children were going to school more, but we didn't see any evidence of cognitive improvement. It wasn't that they were smarter, it was just they were spending more time in school. But a follow-up study by Ogier looked at the younger children in the area. So they would have benefited not directly. They didn't get the medicine if they were just very young because they weren't at school. But they might have benefited from the lower transmission of the disease in their community. And what he found was that for the very young children, the children who are still undergoing child development, their brains are still developing, he saw an improvement in cognition as well, quite substantial, particularly for children whose older siblings themselves got the program. Okay. So I've recently been involved in a long-run follow-up of this, and what we found is quite substantial long-run effects that actually seem to differ some by gender. So for males, we see that they're working more hours. So these kids are now young adults. They're in their 20s typically. So they increase their hours of work by 17%. So one thing to note is there's low hours of work in this community because among these young people, they're farmers, and there's not certain part of the year there may not be that much to do. So unless you move into, say, a manufacturing job where there's more. I don't want to think these are not high-end manufacturing jobs. They're very low-end manufacturing jobs. We also saw higher earnings, so about a 24% increase in earnings. They were also more likely to work in manufacturing.